Good morning, good afternoon, good evening. Welcome to the second session of Day 3 of the first Philippine Harm Reduction Summit. I am Aprille Banayat, Ali, your moderator for this session, creatively connecting with communities' harm reduction principles at work. In this session, let's talk about how being well equipped as service providers is central to an effective response to drugs. Essential idea on this is that it has never been about the drugs. It has always been about the people. Everyone, it is my pleasure to introduce two distinguished people in the practice of harm reduction. The co-founder and director of Clinical Services and Training of Harm Reduction Therapy Center, HRTC, with a mission to train mental health and substance abuse professionals, outreach workers, homeless advocacy groups, and housing staff in the United States, Canada, and Asia. She is also a certified addiction specialist and published the book Over the Influence, The Harm Reduction Guide for Managing Drugs and Alcohol and Practicing Harm Reduction Psychotherapy. Everyone, we have on our virtual stage Dr. Patt Denning. Our second panelist for this session is the Executive Director and co-founder of the HRTC, which provides integrated mental health care and substance use treatment. She is a certified group psychotherapist and works with individuals with co-occurring conditions. She was the first to implement harm reduction therapy in a group setting. Since then, she has applied harm reduction therapy to diverse communities and imparts her knowledge to hundreds of professionals each year. Let us welcome Jeannie Little. So Pat and Jeannie is in the chat, so we can interact them. So you can send a message through the Q&A tab. Pat and Jeannie, take it away.
Thank you very much. It's very, very exciting to be part of this conference and to see all of the work that is being done in the Philippines and all of the support that you're gathering from around the world. So I'm really excited to be here. We have a fairly long video that we'll present. And then after that, we'll have about a half hour left for Q&A. And Jeannie, do you want to?
I'm just looking forward to hearing your reactions to the video and the questions that you have. Thank you for being here.
Okay, you can let it roll, I think. I'm Pat Denning, and I'm the Director of Clinical Services and Training for the Harm Reduction Therapy Center in San Francisco. I'm really excited to be part of this conference that is hoping to really change the way things have been working for you in the Philippines in terms of drug policy and drug treatment and other kinds of services. So I'm very excited and grateful to be invited. And my colleague Jeannie Little is here also with me, and we'll sort of take turns presenting some materials that where the overarching title of this workshop is Expanding Access to Care Using Harm Reduction Principles and Programming. And I think what we've learned is that as countries and localities shift into creating really diverse substance use treatment programs to meet the needs of an increasingly diverse drug-using population, that harm reduction actually offers the most comprehensive and effective range of options. It is a philosophy that can encompass all different kinds of public health interventions that might come under the umbrella of a public health or a substance use department. You know, at its core, harm reduction is a public health series of interventions with the goal of reducing harm to the individual, to their family, and to the community. Whether the harms are coming from unsafe living conditions, disease, lifestyle, drug use, most societies have many harm reduction models already active. Vaccination clinics, traffic laws, prenatal care, and physical disease programs. So expanding such harm reduction activities to drug use and drug users is really a logical and pragmatic approach that can reach many more people. There are several important principles of harm reduction that we use to base not only public health interventions but also drug interventions on. And the principles that have been developed point directly to how services can and should be developed in order to adhere to the principles and provide the greatest good to the greatest number of people. So there are 5 principles that I've outlined, and the first one is come as you are. And how this, what we think about in terms of that being a principle is that people live within their own history and they live with their own culture. And we need to be able to invite people to bring themselves and whoever they are into the treatment situation or the service situation. And if people are invited to come into treatment at any time and in any condition of drug use, then you're actually able to get a much more complete and accurate picture of the nature of their disabilities. Because if you allow people to come in and talk with you no matter what, they'll tell you. They'll tell you what they need and tell you what's going on. And this, inviting people to be who they are creates the kind of trust that ends up resulting in a much more collaborative relationship that can form the basis for true collaborative treatment planning. Come as you are also takes into account the fact that some people are unable to come into your program. And so if a person is coming as they are and who they are is not able to keep appointments, then that's going to inform the delivery of services as well. I think that in general, the principle of come as you are really helps to break down this prevailing idea and attitude that there can be a one-size-fits-all model of treatment. So if we take the principle of come as you are, how this can translate into programmatic specifics is that there shouldn't be any requirement about entry into services. It's not that you have to come in a certain way, dressed in a certain way. There's no preset goal or time limit to the services. So you don't say, you can come here and talk about quitting all drugs today, and you can stay here for 3 months. Come as you are also means creating both extended hours and drop-in hours for services, recognizing that there are going to be some people whose lives or whose responsibilities are such that they have trouble keeping appointments. And in traditional services, those are the people who get left out of services because we haven't been able to adopt to people who are coming as they are, which is maybe not on time. The other part of coming as you are means that we might want to figure out some ways of accommodating family members who are with the person who is coming for treatment or coming for services, but they're not necessarily a focus of treatment themselves. So that might mean childcare, that might mean play areas, that might be waiting rooms that can accommodate family members. So that kind of welcoming of the person's support system while they're coming in for services is a very useful thing. There's also some things about staff and staff training that will enhance that principle of come as you are, that we need to help staff increase their tolerance for difficult behaviors. We know that the more we open up our services to invite anyone in, that there are going to be people who are disruptive or people who are experiencing a lot of stress in their lives or experiencing psychiatric symptoms that sometimes make them difficult to be around or difficult to handle. And so we want to increase staff's tolerance for dealing with those kinds of people, and that means absolutely increasing their skills in how to work with and manage difficult behaviors, including de-escalation. Also, in terms of staffing, it means that we want to make sure that there's staff diversity and sensitivity to the cultures that may or may not be represented by the staff and the client population. We might need to take some services out to the people And actually, come as you are turns into meet you where you need to be met. So you might want to do mobile services and outreach. And Jeannie's going to talk a lot about the mobile services that we've developed over the past couple of years. But thinking about if you really want to expand to enlarge the number of people that you can invite into some kind of a treatment or some kind of a healthcare service, then you might want to go out and find people where they are. The second principle is that harm reduction is a collaboration of experts. And the principle of this is that the client has really important information and expertise regarding their condition. And each client has their own values and their own goals about how they want their life to be. And treatment providers, or healthcare providers, need to have certain skills, and hopefully do have certain skills, like accurate information about drugs. That information that would include not just talking about the harms, but being able to recognize the benefits that people can get from using drugs. And treatment providers also have an expertise in having skills to help a person deal with urges and cravings, to deal with changing habits, to deal with mental health systems that might be disrupting and interfering in their life. So with those principles in mind, how that looks in programming is that we want to actively inquire and respect the client's perspective about themselves and their conditions. That if they're experts on themselves, then we need to know what they know about themselves rather than assume that we can tell them. It also means that we want to allow for various options and treatment methods and goals that are created by both the client and the treatment team. We want to make sure that all psychoeducation information is really accurate and is unbiased by what the provider's own personal belief system might be. And I think it's important to recognize that we may have all kinds of different belief systems about drugs or about drug use or about other kinds of health-related behaviors. And in our personal lives and our personal values, we get to own that. And when we put on a hat as a healthcare provider, we are bound by our ethics to provide accurate information that's unbiased by our own personal beliefs. And sometimes that's difficult. And it's something that can come up over and over again in staff discussions about what gets left at the door in terms of your personal feelings and how do you show up for a client. The other thing, in terms of this being a collaboration of experts is that as much as possible, it's really important to co-locate services. So if you're doing a drug treatment program, to co-locate that with other social services, medical services, something you might call palliative services like food and shelter, medical wound care, and everything like massage and haircuts, but also acupuncture, harm reduction supplies. So what we want is to understand that there is expertise in all of these other fields, and if we can bring them all together on site, that allows people to access these services and take advantage of all the expertise that's out there in our provider community. The third primary principle is that change is incremental. We know that people change slowly over time, and some setbacks are to be expected. If you think about your own self in terms of goals you might have about studying more, or goals you might have about exercise, or about your eating habits, and how difficult it is to make those changes, and how you work at those changes, and sometimes it does not work out so well that day. That's exactly the same attitude and the same way that people who are working and struggling with drug issues change, just the way everything else changes, slowly and with setbacks. So harm reduction then, unlike the traditional approaches, harm reduction really encourages people to enter treatment without having to make any commitment to change. So we actually offer people a treatment relationship where they can think about what they might want to change in their life and get consultation from somebody who has some expertise in that. And so the counseling then is really geared toward helping build a momentum of motivation for change within the client, rather than expecting that they walk in with that. And that clearly will show up in how programs are designed and implemented, which is that we basically want to welcome everybody who comes in. If all they want to do is talk or get information or grab some food or get some harm reduction supplies, that people are welcome even if they're not wanting to talk about change. Treatment always needs to be voluntary and non-coercive, and that is a big difference in a lot of areas of our country. It's certainly different in areas of the Philippines. And we know from an extended body of research that coercive treatment may result in a temporarily being able to control a person's behavior. But it is not effective in helping them both change and maintain behaviors over time. So the more external pressures, controls, and punishments we put on a client, the better control we might have over them, unless they're actually free to run away from our programs. But that control does not actually facilitate a process of change and recovery. And the other thing about really realizing the change is incremental in terms of how we design our programs is that we need to make sure that our programs don't exclude or demote a person for making mistakes or for failing to follow an agreed upon goal. You know, clients will make goals and then not follow them, or decide they don't like that goal, or fail at the goal. There's all kinds of things that happen. And if we punish the person for that by either, putting them back in phase 1 if they've been in phase 3, or discharging them, or setting them out for a certain amount of time, that those punishments really undermine the person's feeling of belonging and acceptance, and undermines their sense of self-esteem. A fourth principle is client choice. And this is just the idea that choices should exist within a menu of options. And there's a person, and Jeannie, you can talk about, is it Jean Heyman? Mm-hmm. Who talks about, can you say something about choice?
Well, Jean Heyman is a behavioral economist, and he studied the phenomenon of addiction and came up with the idea that addiction is a disorder of choice. But he qualified that and said that he wasn't talking about free choice, that for a lot of people, they're making a choice in the absence of any other options, or the perception that they have no other options. Uh-huh. So when he uses the term choice, he's really talking about many people whose lives really do not allow them to find or make other healthy choices. Mm-hmm. And so the choice of using drugs to cope with their life is often sometimes all they're left with. Mm-hmm. So.
And there's research also to back up that people tend to be more successful in any kind of behavioral change, not just about drug use, but they're more successful when they're given options. Would you like to do this or that? Would you like to do this today or tomorrow? And even if a program has a certain outcome expectation, that a program might say that what we want is for our clients to be abstinent. That's a decision that a program can make. The journey toward that decision and the freedom for the person to choose that program in a sea of other options makes it a perfectly legitimate and perfectly harm reduction friendly approach. So harm reduction and abstinence are not opposing here. It's a matter of choice and menus of choices. So again, in terms of how this comes down into everyday programming, the clients will have a choice of goals that could include complete abstinence, abstinence from one but not all drugs, learning how to use more safely, actually being trained or coached in moderation, and other methods of controlled use, where the goal then is to reduce the maximum amount of harm that's being done to the person, to their family, or to the community. Also means that we want to offer a menu of modalities: individual, group, family, couples, small groups, large groups, ways for people to interact with each other, case management, medication-assisted treatments, harm reduction supplies. So all of these options are available so the person can say, well, I actually don't want to use any medication, but I could certainly use that drumming group that you've got going, or I could use some family work. So to have all of those choices makes a huge difference to people. Outpatient treatment, that can range from occasional sessions to regular sessions, with the intensity of the outpatient treatment really guided by client choice and their identified needs. I really need to talk more about this, or I need to go to my job and not come here so often. So those kinds of choices about intensity should not be made primarily by the program and only based on the severity of the problem. The client needs to have input into the intensity. And that really brings us into residential treatment. I know that in a lot of places residential rehab is one of the primary treatment models, but I think it's important to think about residential treatment that we might want to limit it to clients who are in need of or who are asking for a lot more structure, for some immediate safety, for some respite from the chaos or the danger in their life, and not because the provider wants more control or coercion. So residential treatment ends up being a haven for people. It becomes a place where people will want to go rather than have to be coerced to go. And finally, the last principle is that the work needs to be sustainable. And this is where we start thinking about harm reduction for staff. Our staff if staff are going to be respectful and committed to their clients, their own welfare must really be a priority of the treatment service. And that means recognizing that working in a harm reduction framework can cause incredible anxiety and fear and worry and sometimes anger toward our clients. And that compassion fatigue is a real thing, and that it can cause a decreased quality of care and a lot of staff turnover. So with those principles and those concepts, what we can look to in terms of programming is that we need to provide staff with adequate supplies, adequate environments, rest breaks. We need to protect staff from working too much in isolation. We need to provide staff with regular individual and clinical supervision and allow them to receive informal education and emotional support by peers, by mentors. We want to make sure that the agency provides leave time and monitors that staff take that time off. And finally, to the program to provide opportunities for staff bonding, parties, celebrations, group activities. That this ethic of taking care of the staff will encourage and really allow them to be committed long-term to providing really compassionate care. Thank you.
I'm Jeannie Little. I'm the executive director and co-founder with Pat of the Harm Reduction Therapy Center. And I'm going to talk about the programs that we've been developing for the last 20 years. We have had a kind of an accidental growth based on the fact that we were training therapists to practice harm reduction therapy, which means they were learning to integrate substance use treatment into their mental health training and their mental health practice. And I was doing consultation at a number of community-based organizations, HIV service organizations that operated drop-in centers and drop-in medical services, other community-based drop-in centers, supportive housing organizations, and several other community organizations providing social services. At some point, a couple of those agencies asked if they could contract with us to get some therapeutic services. They had case managers, they had doctors, they had nurses, they had employment specialists, but they did not have anybody providing mental health or substance use counseling. So that began that really began our community programs. We started embedding harm reduction therapists in other people's social service organizations, and we would exchange referrals and work collaboratively as a multidisciplinary team. And that type of program for us grew to be the largest part of what the Harm Reduction Therapy Center does. And at one point, we had collaborative relationships with 10 other organizations, with a fairly small staff of 10 or 12 therapists. We became very skilled not only at working with clients in many different environments, in many different neighborhoods, clients from many different backgrounds, but we also became very skilled at collaborating with staff who came from a lot of different work cultures. So in about 2017, the Department of Public Health in San Francisco started studying the problem of why large numbers of people experiencing homelessness were not in care. They were not in medical care, they were not in mental health care. A large percentage are people who use drugs, and they were not in any kind of substance use treatment. They lived very isolated lives in their own little communities and encampments, or even living isolated. And the department wanted to figure out a way to reach those folks. It was clear that the existing clinics that we have, the mental health clinics, the drug treatment programs, the medical clinics, just don't work for a subset of folks. And we have about 14,000 homeless people in San Francisco, and about 4,000 of them have serious co-occurring disorders, medical, mental health, and substance use, and are in really bad shape, and are utilizers of a lot of emergency services, and are, although they use emergency services, they are really not connected in a meaningful way with treatment services or medical services. So the challenge that was really thrown down is to find more creative ways of connecting with those people and engaging them in treatment and in care. And we were approached to apply for a city grant to experiment, really to make up something completely new. And we were approached partly because we practice harm reduction therapy, and we welcome anyone. And partly because we have been so successful at working in so many different communities in very low threshold settings. And people know that if you're working in a clinic and you're working with somebody that you don't think you can handle, you're going to call the Harm Reduction Therapy Center. If you kick somebody out of your program, but they need to see a counselor, you're going to call the Harm Reduction Therapy Center. because we practice all the principles that Pat just talked about. So we were asked to just, here's some money, go make it up. So
I also just want to point out how unique it is for a city Department of Public Health or any governmental agency to literally give money, even though we are, of course, wonderful and well respected, but still for the government to say, you figure it out for us because we don't know what the best thing to do is. And that's a great opportunity for other localities, other countries.
Absolutely. That's true, is find the people who are doing the most creative work, find the people who are comfortable working with the most difficult folks, seek them out and ask them to help you. So the first thing we did was we set about doing a needs assessment. So we knew the neighborhoods where folks living on the streets were most densely populated. And by the way, although these services I'm talking about homelessness, that's not all the target population. We're also talking about people who do have housing, but whose lives are so unstable, their diagnoses are so complicated, that they too are not really engaged in a meaningful way in ongoing care. And they are also folks who tend to hang out on the streets, even if they don't live there. And in San Francisco, as you may know, we're fairly famous for our street-based drug use. I think probably it's true in a lot of cities, but San Francisco is very small. It's a tourist destination, and so our public drug use is very visible. And a lot has been made of it in the media. So what we did was we went to both people living on the streets as well as organizations working with them, and we conducted a needs assessment, and we had a map. So we made this map about 3 years ago, and we started pinning, we started finding the neighborhoods where we might be most needed. We made a cute little, you can't really see this very well, but a cute little picture of a very colorful van, and I'll explain that in a minute. And we started mapping out where our services might be needed. The second thing we did was we started thinking, if we're going to attract people to come and talk to us, then what do we need to have available for them? Well, nobody's going to talk to anybody that they're not comfortable with. And so what do we do to make people comfortable with us? Well, we have to think about what they need most. You're going to be comfortable with somebody who gives you what you need. Well, we're talking about people who are living in often extreme poverty, who are sometimes living on the streets or living in very crowded housing. And if you're living on the street, you don't necessarily even have access to clean water. So we decided that we would travel around, and we would need to have some food and some water and some comfortable chairs. Well, then, so we were thinking, okay, so we actually need a place to sit. We need to be visible. It's likely to be raining sometimes, so we need canopies to put up so that people can actually sit out of the rain. And we need a private place for people to talk to somebody when they're ready to talk. It's not going to be realistic because we have really very, very little office space and program space in San Francisco. We're very crowded. So maybe we need to take an office with us. Well, how do we take an office with us? We buy a large van. So we bought a large van. We converted it into a counseling office, and with the van and with the canopies and with some tables and with some chairs, we started setting up mobile pop-up clinics or mobile pop-up drop-in centers.
And comfortable chairs.
Comfortable chairs.
Rocking chairs.
I bought rocking chairs. I bought soft canvas, like director's chairs that you could kind of sit back in and get comfortable. Coffee tables so that fruit and things to play with and information about drugs all could be scattered on the table. And in regard to the food, outreach workers always carry some snacks with them, and they're packaged snacks, they're crackers, they're nuts, they're maybe some fruit, cookies, that sort of thing. I am a big believer that if people who are hungry are going to really feel satisfied, they need warm food, and it needs to have protein in it, and it needs to taste good. So the best way to achieve that was to build a kitchen. So we also bought kitchen equipment and started making soups and grilled cheese sandwiches, which is a very popular item in the United States. It was a very fast and a very easy process after we set up in a given neighborhood, and we ended up setting up in 6 neighborhoods where we brought our food and our chairs and our canopies and our van and our therapists. So what happened next was, of course, lots of people came around to see what was going on. We were able to explain who we were able to explain harm reduction therapy, and we were able to say, you don't have to do all that, but we'd be more than happy if you'd have some food, and if you feel like it, have a seat. So we did this for a few weeks in these different neighborhoods, and of course it didn't take long before one person, then 2 person, then 3 people would say, well, actually, could I talk to you about? And then they would start to describe their needs. It was not long before we had between 30 and 200 people show up every day, depending on the neighborhood we were in and depending on how densely populated the folks on the street were in that neighborhood. This was a very popular service, which is what we were going for. Well, then what happened is other service providers started noticing what was happening, and they said, well, gosh, you all have all the clients. Can we bring our service to you? So we ended up, and I'll describe more in a minute, but we ended up with a situation where instead of our therapists going to other drop-in centers with multidisciplinary services, we became a multidisciplinary site on the streets. So at our largest site, we had San Francisco street medicine team, a hepatitis, HIV, and STD testing team. They came every day. A massage therapy team, which of course was very popular, in addition to having warm food and organic juices and water and fruit and everybody's favorite, we had cheesecake for dessert. And I'll explain why we had cheesecake for dessert, because I was thinking everybody wants something sweet. This is a group of people that has intermittent access to protein. We want to have food that's really going to stick around for a few hours. And cheesecake is delicious. Everybody loves it, and it's full of protein. It's very filling, and it lasts for a long time. So we had extremely popular meals. The word on the street is that we cook better food than anyone. Better food than the soup kitchens, better food than the other organizations. And we do this on purpose. It's not like we're trying to compete with other organizations, but we know what people need. And that's what we bring them. So the massage added on to this lunch was just incredible. And people need so much care, and the level of relaxation and the willingness of people to then engage in talking with a therapist about their problems was so increased. There were times actually that people would say, I don't think I can talk to a therapist unless I'm getting a massage. And so the massage therapist would move the massage chair. We use chair massage rather than table massage because it works better in the street. Move the massage chair to a private place, like across the street on the sidewalk, And the therapist would sit in a chair in front of the client while the client was getting a massage. And then the client was able to talk. The same would often be true with medical care. The medical team that works with us is quite amazing. They are willing to do anything for anyone. And often there would be a line of chairs down the sidewalk with people waiting to see the nurse. And a lot of people with open wounds, either related to injection drug sites or related to, for example, wounds that weren't healing because the person had diabetes. And the nurse on her knees would go down the sidewalk and wrap people's wounds. She would clean their legs, wash them, put ointment on their wounds, and then wrap their wounds. We do not have photographs of this because we don't take photographs of our clients, but if you can just imagine how amazingly beautiful this service is.
Wow.
The other person we invited in was an acupuncturist who would specialize on the streets in kind of relaxation acupuncture, which is done in the ears. And same thing, we would have a row of we would get lounge chairs so people could lie back. A row of people in lounge chairs with yellow tipped needles in their ears. Just a beautiful sight. And then a therapist would just go sit there, and then people would just start talking about, what's going on in their life and what they need. And then we also had advocacy groups who would come and help out as well. One organization would bring an attorney so that if anybody had any legal issues, they could speak to the attorney right there. Unfortunately, we had to close these pop-up clinics down for the pandemic, and so we're just waiting for the opportunity to build them up again. One comment that we got, one of our sites, and we do continue to do outreach. We have a modified service now. We do continue to outreach at all of our sites that we had our clinic pop-ups at, and we still take lunch. We now have somebody who manages our food service, and she cooks all the meals at her house and packages them up and then brings them out. We now have 3 vans, one of which is our food van, and that also carries our harm reduction supplies. So she'll bring food out and deliver it to people while we're actually doing walking around outreach and maybe sitting on a bench and talking with someone. So we're trying to keep contact with folks. We're trying to keep regularity, because one of the things with people whose lives are unstable, and one of the things with people who have had a lot of bad experiences with institutions, medical institutions, social service institutions, they have felt rejected, they have felt judged, they have felt unwelcome unless they were willing to do what the program wants them to do. They don't trust institutions, and one building block of trust is to be reliable. So we have been reliable all the way through the pandemic. We have showed up every week since the pandemic started. We just haven't shown up with all of these services, unfortunately, although we do still walk around with the street medicine team. One of our sites is beside a park, and the park has a couple of park staff, one of whom monitors the bathrooms. And after a few weeks, they started to tell us that for the people who hang out in that park, on the days that we're there, which is Wednesdays, the park is always calmer. There are fewer fights. People drink less than on other days. It's a big drinking park. People drink less, they fight less, and they also spend more time talking to each other. Instead of sitting in small, either by themselves or in a couple of people around the park, they'll gather at a picnic table because they want to use the picnic table to eat our lunch, and they stay there in a large group for the rest of the day. So the social environment and the behavior changes just in response to the 2 or 3 hours that we spend at this site.
Right. The power of food and kindness.
And kindness.
Yes,
Yeah.
that's, yeah.
Yeah.
Mm-hmm.
Food and kindness and concern. Absolutely.
Mm-hmm.
Absolutely. There's a lot of, as you can imagine, there's a lot of positive feedback from the folks who visit our sites. There are a lot of recommendations by word of mouth. Somebody comes and sees what we're doing and then goes down the street and says, you really got to come up here. You really got to come up here. You can talk to these people. This is a direct quote. You can talk to these people. They love us. Which is,
Mm-hmm.
I think that's the lesson for us, is that if we want people to want to work with us, and if they want to work with us, they will get better. They will not get better under coercion, but they will get better if they're getting helped by somebody that they actually want to work with, and they want to listen to, and they want to talk to. And to achieve that, we have to truly care. And we have to do things, and we have to structure our programs in such a way that we communicate that we really care. We have thought about you, and we have thought about what you might want, and we have thought about what you need. If you tell us what you need, we'll bring it to you. And that creates a relationship of cooperation. And that it really creates the relationship that Pat was talking about, a collaborative relationship of mutual experts.
And I think also that it's not usually being taught in schools for social workers or psychologists or therapists, drug counselors. We're not taught to approach people in that way.
Right.
And so I think one of the other amazing changes that has occurred is having therapists get used to not having an office and not having rooms that people come in and go out of, and really having a therapy without walls.
Yeah.
And it's a very different experience for the provider.
Yeah. Well, and that really embodies what Pat mentioned, the word control several times, that often our programs are set up so that we feel in control. Mm-hmm. When you go outside and you work on the streets or in somebody else's drop-in center, when you work in an environment that is really somebody else's territory, you have to give up control. You are a visitor, and you need permission to be there. How do you get that? You get that by bringing what people really need. And once you have permission to be there, that's the beginning of a working relationship. Yeah.
Well, right, because when people are living on the streets and we go and set up, we're actually walking into their living rooms.
We are. It's true. We're walking into their living rooms.
Kind of.
Yeah.
Seems kind of rude sometimes.
Yeah. Well, and we're really co-creating a living room. We set up a living room. That's actually how I like to think about it. We set up a living room next to, their front porch, let's say, or next to their tent, or next to the park where they hang out. Even though they do have a room to go sleep in, but this is their daytime home. And we create a space where the rules are a little different. That doesn't mean we have rules. We actually have no rules. That may be the topic of another training. We have no rules, but there is an atmosphere that we create, an atmosphere of respect and an atmosphere of we're not going to get in each other's faces, and we're not going to tell each other what to do, and we're not, and you all aren't.
Mm-hmm.
So we do create a little bit of a different environment which has different expectations. And so together, we're making, we're making a home together for a few hours.
I remember some incident where somebody was sort of trying to pick a fight maybe with someone.
Yeah.
And used a couple of slurs, and one of our staff just kind of walked past and said, "Not cool, man." And that was the level of intervention and the lack of coercion and control that was still giving a message of this culture here is a culture where nobody disrespects anybody.
Yeah. I'd love to ask you if you have any questions, but you all are over there and we're here. So
Well,
maybe that'll happen some other time.
Well, and it will, because the way the summit is being set up is that you all, as the audience, I guess, will have all sorts of opportunities to watch this video. And then there will be a scheduled hour-long session with Jeannie and I that is just question and answers that will be live.
Great. Okay.
Yeah, so think of what questions you might have.
Okay. And
We'll
thank
be
you for
back.
listening. All right. Thank you.